And when people start talking insurance, we get kind of like, oh God, I don't know how this stuff works. And then we're not showing up as our best selves. And so a big goal of today is that you can walk away from this with some more confidence, just from just getting Walter's aura of confidence. So just stare at him for a while, and you should be able to walk away feeling a little bit more confident. But we're actually going to do now, to start off and just get a baseline, also to get people engaged, is I'm going to switch over to a, where'd it go? This guy. Am I still sharing my screen, or do I have to do that again? Still learning all this stuff here.
You were good before.
I was good before, okay. So here we go, I think I'm good again. So we are gonna start off with a game. This is called Kahoot. And if you just go to kahoot.it and enter that number, 2576104, you will also have to put in a nickname. And we'll try to get as many of you in here as possible. Please start doing that now. I would recommend doing it on your phone if you are joining this webinar on your computer, so that you can see on your computer, you can see my screen. Hi, Candy, I see you on there. Hi, Aaron. And then we will go through some insurance terminology and kind of see what our baseline is. Just letting you know, this gets pretty intense. It's a fast-paced game, so expect your stress levels to spike a little bit. Ride that wave and have fun with it. So I've got 3 people joined already. Hi, LB. Oh, here we go. People are coming in. We'll give it another minute or two for everyone who's on to be able to join in. You got 9 people joining. Sweet. Gina, how many people do we have on total at this point? 20, oh, here it is, 21 people. Oh, now I found out how to see everyone. Learning as we go. Okay, so it seems like almost everyone is on at this point. And then I'll pull up the chat. Okay, here everyone's saying hi. Awesome. Okay, so I've got 17 participants and only 13 players. There's 4 more of you out there. Anyone struggling, feel free to join in the chat if you're struggling to get in. One thing I forgot to mention, you don't have to use the Kahoot app. You can just go directly onto the website and type in that code. So you don't have to download anything necessarily. Awesome, we'll get going in 15 seconds. Okay, here we go. So we're gonna start off, and this is just the intro slide. Don't get too excited yet. Boom. Number 1 question, what does in-network mean? And now you will choose on your phone app which of these things is the right one. So just click the corresponding color. Five more seconds to select your answer. The faster you select it, the more points you get too if you get it right. Okay. So we will return to this once we get into Walter's slide, but looks like most of you guys got this right. Going on to the next question. CW's in the lead. Fastest answer. Fastest correct answer, that is. Here comes the next question. What is an allowed amount? 5 more seconds. Just get anything in, better than nothing. No penalty for getting it wrong. You just don't get any points. Nice. Strong work, everyone. CW's still in the lead. What is a copay? Five seconds. Okay, most of you guys got it. Walter, you kind of taking notes on which ones we want to address? Oh, Candy pulling into the lead. Very close. Next question, what does out of network mean? Nice. Still, you guys are good at this. So most people got that right. A provider does not have a contract with your insurance company. And Bree has the highest answer streak of 4. Candy's faster. What does balance billing refer to? Nice. Wow, people are crushing it. Oh man. Staying pretty tight. What is coinsurance? Oh, this is a good one to cover. This could have really made a difference. Let's see where we're standing. Oh, Bree pulls into the lead. Okay, do we have any more questions? I can't remember how many questions we had. Oh yeah, this one and one more. What is a deductible? Strong work. 100%. Okay, we don't have to cover that one, I guess. Moving on. Bree holds under. Ooh, man, it's gonna be hard to catch you, Bree. Last question, everyone. Okay, total member responsibility during a benefit period is the correct answer. And now for the grand reveal. Nice, strong work. And getting all questions correct. Woo-woo! You guys can't hear it, but I'm hearing some great music in my ears. Celebratory music. And some screaming, clapping, a lot of applause happening in general. So thanks everyone for playing, and congratulations to our podium. And I will turn it over to Walter to talk about these things in some greater depth. Okay, Walter, I'm gonna go on mute, but I think I unshared my screen, so you should be able to share yours now.
You should be good, Walter.
Okay, thank you. I think everyone can probably hear me now. Please let me know in the chat if we're not able to hear me. All right, so thank you very much, guys, for giving me the opportunity to come and sit with you and spend some time and connect. This is really neat for me, and I'm just super excited to talk with you guys a little bit about insurance. And I think the game was really fun for us all, and it was really neat to see you guys do so well on that. Some of those answers were intentionally confusing a little bit, but everybody seemed to do very well. So nice job there. We'll definitely cover that terminology and answer any questions that you have. So if you do have questions, please feel free to just put those in the chat for us all to see, and we'll talk about that. So our topic for today is going to be about insurance, and we're just going to broadly kind of touch on everything insurance kind of related and start with some real basic stuff. And kind of go from there. My goal for today is to create an opportunity for us to dialogue, and we will open up the session at the end and have some opportunity to dialogue with one another and just see where everyone's head's at and what conversation this sparks and where we want to go. So if you have questions or you would like me to touch on something more clearly, if something I say doesn't make sense, please just type it in the chat and we will we'll cover it. So without further ado, we will start the presentation. So this is going to be insurance and the joys within. So first, why are we here? So we would like today to empower our community to dialogue about insurance as it relates to the behavioral health industry and gain increased understanding and confidence. So it can be a fairly intimidating thing, and I think that's largely because there's so much uncertainty and emotion that's wrapped up around it, and especially right now, emotions are running high. Fear is pretty pervasive throughout. And so that's something that we just want to be aware of. And this insurance is something that we can all understand and we can all talk about. So that's why we're here. So our agenda for today is going to be to look at this terminology and a communal set of definitions that we can all use. The definitions that we give today are going to be fairly basic, And there are more in-depth areas that we can get into with each of these terms, and there are one-off scenarios that all of these terms can apply to. And we've all seen and heard horror stories when, you know, it doesn't work exactly the way we were expecting it to work, and we all know somebody who got hit by a surprise medical bill or had a bad experience with a provider. But generally, we want to give some definitions to the terms that you know, you just saw in the game, and just make sure that we're all on the same page. Again, if you guys have questions, just type them into the chat, and or we can also discuss them openly at the end of the presentation. Then we'll take a look at calculating out-of-pocket costs. I think that's one of the big things that everyone always gets confused on, and there's so much just fear surrounding it. The question of how much is this going to cost me? You know, how much do my medical services cost? And so we'll take a basic look at how the out-of-pocket costs are calculated. Then we'll have a short section on myths and legends, and we'll do some Q&A there and see if anybody has questions or topics that they would like to talk about. And then we will touch on fear-based communication and what to do instead. So often in my role, what I get exposed to is clients and families that need help, and they need it now, and they're very scared, and that's understandable. And so how to approach those conversations. So moving on here into terminology, here's the terms that we're going to cover today quickly. We'll cover in-network, out-of-network, deductible, coinsurance, the out-of-pocket maximum, copay, a claim, allowed amount, and balance billing. So the first term that we want to look at today is in-network, and the communal definition that I would like for us to use today, and again, this can get more complex than this definition, but for today, just to make sure we're all on the same page and we can all have a discussion, the definition is that the provider has a contract with the insurance company to accept a negotiated rate, and the members' in-network benefits will apply. So in-network, out-of-network, is that the provider does not have a negotiated contract with the insurance company, and the members' out-of-network benefits will apply. Common example of when this gets confused by people seeking services is when they'll see an insurance logo on a website, or they will ask a provider, do you accept my insurance? And sometimes the answer will come back as, yes, we accept your insurance, but that does not necessarily mean that that provider is in network. The best way to determine if a provider is indeed in network is to ask the provider and then ask your insurance company. And if both of those give you the same answer, then it's correct. If there's a difference in answer, then we need to do some more digging and understand a little bit better. Next term is going to be deductible. A deductible is a specified amount of money that the insured must pay before an insurance company will provide any coverage. All of us actually know what a deductible is and how it functions. We all have car insurance, and before our car insurance policy will provide any coverage for us, we are going to be subject to our insurance deductible. Well, this works the same way here with healthcare. Before a healthcare insurance company will provide any coverage for you, you must pay out of your own pocket the amount of your deductible against your provider's claims. Next term is coinsurance. Coinsurance is a variable percentage in which the insured pays a share in the cost of a procedure, service, or medication. And this is a form of cost sharing, and is very common. Almost all insurance policies will have some form of coinsurance at some point. We'll see it as a percentage breakdown, and it's usually like 80-20 or 70-30, 60-40, something like that. And one thing to note is that whenever you hear these numbers 80-20 or 70-30, almost 99% of the time, the bigger number is going to be the insurance company's responsibility, and the smaller number will be the member's responsibility. So, and coinsurance can be applied to your claims for procedure services or medications up to your out-of-pocket maximum. Once your out-of-pocket maximum is met, coinsurance will no longer apply. So next term is going to be out-of-pocket maximum, and this is the maximum set amount of money a member will pay out of their own pocket in a year on covered medical costs. So this is also known as a stop loss, and what this does is it governs the total amount of money that a member can be responsible for paying out in a benefit year. And most benefit years do run on a calendar, but you can have plans that run on a plan year, which can start any time of the year and run 364 days. So most of the time, generally, it's going to be from January 1 to January 1, but you can see plans that start in April and in the 31st of March. So that does happen, but the out-of-pocket maximum will reset every year the policy does. So you'll get a new set of possible expenses every time your policy resets, but this is your maximum that you will pay out. Copay, so this is a fixed amount a member pays for a covered service to the provider. Most medical providers will collect the copay at the time of service or right before. And these are very common. We've all seen this happen where we'll go to pick up a prescription or we'll go to a doctor's visit and they'll collect from us, you know, a small amount of money, some $10, $20, $50, $70 on a copay. And this is another form of cost sharing. And all of these forms of cost sharing, deductibles, coinsurances, and copays, these were introduced in an effort to reduce the total financial burden on the medical system. And what studies show is that the more people are responsible financially for the medical services, the less they access those services. And so not necessarily taking a side on that and saying what's good or right or should be done, but that was the thinking when these measures were introduced into insurance policies, is they were designed to increase the individual seeking healthcare, their responsibility financially for that healthcare, which in turn was supposed to reduce the total amount of healthcare accessed through this system, and reduce that burden. So next term is going to be claim. So an insurance claim is a bill from a provider requesting payment for services rendered to a member. So every time we provide services, and most of us are going to know this, this is probably very rudimentary for most of the room, but every time services are provided, we have to submit an official claim to an insurance company in order to get paid. And those claims have to be submitted via a particular form with a particular format and using specific coding. And that form has to be submitted in a timely manner with the correct authorization backing it up in order for that claim to get processed. And it's one of the target areas that insurance companies will use to try to deny services. Allowed amount, this is a pretty confusing thing if you've never heard this term before, and it is the maximum a plan will pay for a covered healthcare service. It's also called an eligible expense, a payment allowance, or the negotiated rate. So when a claim is submitted and the claim is determined to be valid and payable, then an allowed amount is assigned to the claim for that service. Regardless of what the provider bills for the service, the payer will assign their own allowed amount of what they feel that service is worth. If you're in network, then the rates are already negotiated and the allowed amount is your contract rate for the service. If you're out of network, then it's fairly gray and there is a lot of wiggle room there for both the provider and the payer. So that's where a lot of fraud and unethical billing will take place, is on the out of network side. Balance billing. So this is sometimes called surprise billing. It is a medical bill from a healthcare provider billing a patient for the difference between the total allowed amount and the total charge amount. And so after a claim is submitted, a payer will assign an allowed amount to that service. After that, previously in the past, a provider has had freedom to then bill the member, the person who received the service, the difference between the charged amount and what is allowed by the payer. And that difference there, that's where all of the horror stories come out of Florida and Arizona for fraudulent billing practices, surprise billing. That is the area where it comes from. And there is new legislation that is coming out across different states that is going to protect people from this. And it is considered to be unethical to do this. So next is we're going to be talking about calculating an out-of-pocket cost. But first, let's just take a quick pause and see if there are any questions so far on any of the terminology. Does anybody have anything that is unclear that you want me to circle back on and spend a little bit more time on? Or is all of this pretty rudimentary, pretty basic? Everybody have a strong understanding? And I can just hang on for 60 seconds and see if there's anybody that has any questions about terminology or the definitions. If anybody does want to ask questions, that's great. If not, we will just go ahead and move on. But I just want to give the room a couple of seconds here to think about all of the terms that we just went through. And if they're very elementary to everyone and everyone does understand them perfectly, then we'll just keep moving on to the next part of the slideshow. And it is going to be most people's favorite because it does involve some math. And so it's pretty exciting stuff. And yeah, I don't see any questions popping up in the chat. So we're going to go ahead and start taking a look at the next part here. So next, we want to look at calculating an out-of-pocket cost. And we're going to look at this from the lens of an in-network provider. So an individual seeks healthcare services from an in-network provider. That's a provider who has a contract for a negotiated rate with their insurance company. And how do we determine how much this person is responsible for paying? How do these terms, deductible, copay, coinsurance, how do they actually work in the real world? And so looking here, if we assume that for a particular service, the contracted rate was $1,000, maybe this is a day of detox or something, and this person is going to go in for a day of detox, and their deductible is $200 and their copay is $50 and their coinsurance is $20, how much money is this person actually responsible for? And I'll give the room just a couple of seconds if anybody wants to take a stab at it, but I'll move on here in just a second. But it's pretty interesting how it all works, and there is, you know, a lot of confusion and fear around this, and most of the time the big fear is how much does it cost, right? People want to come into the programs, they want to get help, they want to access care, but they do not know how much it's going to cost. And then a lot of times, if we're not working on the insurance side on the daily basis, if we don't really have a strong grasp on this information, our answer is, I don't know. And that is, and that it creates additional opportunities for, you know, fear, for us to make fear-based decisions. So there are, here we're just going to use this example to see if we can get a little bit better understanding of how this all works. And so yeah, so I see some people throwing it out there. So those are all really, really close. And I'll show you guys the next slide here now that shows the answers. So here you go. So the service rate contract of 1,000 with a deductible of 200, a copay of 50, the coinsurance of 20%. Insurance is going to end up paying $600. The client will end up paying $400. And the reason that it is that way is because the copay comes out, the copay will be applied to the total contract rate before the coinsurance. So the order in which it will happen is deductible, copay, coinsurance. So I will go ahead and take you to the next slide. And here is the actual steps and how this all works. So initially we started with a contract rate of $1,000. So we minus the $200 deductible, that gives us $800. With $800 remaining, we're going to subtract the copay, $50. That leaves us $750 of eligible expenses. $750 times the 20% coinsurance is $150. So the member is responsible for $200 on a deductible, $50 on a copay, $150 of coinsurance, totaling $400. So the contract rate minus the member's share is what the member will pay. Hopefully that makes sense to everybody, and feel free to say that it doesn't make sense or that we need to spend some more time on that, and we're happy to do that for you. So
Walter, we do have a couple of questions and comments.
Yeah.
One is sometimes the copay doesn't apply to the out-of-network.
Mm-hmm. Yep.
Can you speak to that a little bit?
Yeah, sure. Yeah. There are a lot of times when the copay is not going to apply out of network. So it is a really good idea to have a full verification of your insurance policy done when you're going to seek medical services, so that you can fully understand the expectations that you'll need to meet. And every insurance policy has the potential to function differently than all the others we've seen before. An insurance policy can be written by an individual or an employer group or a group of employers in any number of ways, and they can be very, very specific. They can have special limitations, special exclusions, and it's just based on the amount of contributions that the individual or employer group is able to make towards the policy and what they want the coverage to be available for. So for instance, in a catastrophic only policy, you may have very low monthly premiums and very low contributions expected from the employer group. You may have a higher deductible and a higher out-of-pocket maximum. And so thereby, the policy is not designed to cover routine or preventative services. It's not designed for your yearly doctor visit. It's not designed if you get the flu or something like that. But if you have something catastrophic that happens, a severe injury, cancer, you have to go for dialysis, ongoing or something like that, then your policy will kick in after you meet your responsibility, which could be a lot. Let's just say it's as much as $10,000 or $20,000, but your total medical expenses could be in the hundreds of thousands of dollars. And so then the catastrophic policy will cover the bulk of that. And while $10,000 may be a lot for us individually, hundreds of thousands of dollars would be crushing, and we would never get the care that we needed without that catastrophic policy. And then other policies can have the co-payment and co-insurance and deductibles. They can be set individually to apply specifically to certain services, to certain diagnoses. They can be set to apply in or out of network. So there is a wide range of options that a policy has when they are written, and you really don't know what a specific policy, how it's going to function, until you call and you ask the insurance company how that functions.
And then I had
Go
one
ahead.
more follow-up on that. How does the copay apply towards the out-of-pocket max?
Yeah, so sometimes it is included in the out-of-pocket maximum, and it can be excluded. You can also exclude coinsurance. You can also exclude a deductible from an out-of-pocket maximum. So most of the time, what we see is the deductible, coinsurance, and copay are included inside the out-of-pocket maximum. And once the maximum is met, that is the end of the member's responsibility for that year. However, a plan can have a special limitation or exclusion written in there that says, hey, the coinsurance or copay is excluded from the maximum, meaning it goes on forever. So if my out-of-pocket maximum was $5,000 and I pay that out inside my benefit year, but I'm still receiving services, if my copay or coinsurance is excluded, then I'm going to continue to pay that. And usually when that happens, it's for a specific service or diagnoses. Does that make sense?
I think so. I've got one more here, which is how common is it to have self-pay discount rates and published rates? Could you discuss the difference between those two?
So self-pay discount rates are fairly common. I don't know how common. I couldn't speak to that without doing a little bit of research, but most of the time you'll hear about, private pay rates, and a lot of providers frankly would prefer their members, their clients, to pay privately cash, because dealing with insurance companies is a huge pain in the neck. And it is very expensive to deal with insurance companies just from a manpower standpoint. So there are a lot of providers who just completely don't do it. And there are a lot of providers who will say, hey, if you're going to cash pay, if you don't have insurance or you would like not to use your insurance, then that's totally up to them to do. The rule on this is a provider is supposed to have their cash pay rates set at the same rate as what they would bill to an insurance company. So you're supposed to bill a private individual the same amount you would bill an insurance company. And it is a rule or a guideline. I haven't seen it on the federal level. Maybe it's there and I can do some more research into that. What is there are laws that state that you must bill each payer the same. So I can't bill Cigna one rate and bill Anthem another. I have to bill them all the same for a given service. So I can't change the billed rate between insurance companies. That's a law, but the private pay discount, I have seen it. It does exist. My best understanding of it is that it's a little bit gray on that area, and I can do some more research and maybe get the room a hard answer on that, if that would be helpful.
Yeah, thank you.
Yeah.
That's all the questions we have typed up at this point.
Cool. All right. Well, let's take a look at what's next on the list here. So questions and answers. So we do want to pause just for one moment and see if the room has any other questions about anything that we've covered so far, any open discussion. Is there anything that's in your mind that so far has been prompted that we would like to talk about, that you would like to answer? I've been doing this stuff for a long time, and maybe until we get a couple questions. Go ahead.
Yeah, we have one more follow-up, which is to that last question. That doesn't mean that all insurances will pay that billed rate, though, correct?
Yeah, that's correct. So most providers set a billed rate well above what they actually expect to get paid. And there's a very, very clear reason for doing this. And that is, since on the billing side, when we're strictly talking about billing to an insurance company, this is solely about money. It is the payer's job is to not pay the money, and our job is to get them to pay the money. And they're going to avoid paying that money at all costs because it's money. So if a provider creates a claim on an out-of-network basis and submits it to an insurance company with a reasonable rate on the claim form, like let's say for an individual session, I bill to an insurance company $100. Okay, that could be very reasonable rate. Maybe it's a little low, maybe it's a little high, but that's probably fairly reasonable and accepted. An insurance company is going to come back and pay you $22 because they are going to pay a percentage of what you bill out of network, and they expect you to bill a much higher rate than what you need to get paid. And so the industry has been forced to bill higher rates than what we expect to get paid, which is why so many people are terrified when they get these explanations of benefits, when they see what the numbers on the paper look like and how much they add up to. This has also created that opportunity for the surprise billing, for the balance billing. This is where it all comes from, is because if I treat the insurance company, if I treat the payer fairly and I put the true cost of the service on a piece of paper, they won't pay it. So I have to exaggerate the cost of the service. And again, this is when I'm out of network, in order to get paid a reasonable amount. When I'm in network, it doesn't matter what number I write on the piece of paper, they're going to pay the contracted rate. Does that answer that question, Deidre? Does that feel good?
Yes.
Awesome.
And then kind of to follow up on that question as well. So for the in-network though, it sounds like it's the negotiated rate that's what it's there for, is you bill that rate and you get paid that rate. Is that accurate?
So are you talking when we're in network and have a contracted rate?
Yes. Okay. So we've got a contracted rate for a specific service.
Yep. Yeah. So my billed rate, my charge amount never changes. It's always the same whether I'm in network or out of network. It's just when I'm in network, the insurance company completely ignores my charge amount. And this is a good point here, Rowan, and thank you for asking that, is the number that a provider writes on the piece of paper is absolutely meaningless. It doesn't mean anything. The only number that means something is the allowed amount. So once an insurance company assigns an allowed amount to a service, that's how much that service is worth. Now, sometimes an allowed amount will be assigned low and we'll have to go in and fight for that allowed amount to be changed, but the billed amount is completely meaningless. It is an arbitrary number that's put on the piece of paper, and it's the provider's kind of only chance to financially leverage against these giants, these companies that have billions and billions of dollars, and they control people's health. They control the community's access to healthcare, and so they have lots of power. And so our only opportunity to financially leverage against them is to write numbers on a piece of paper. But ultimately, they are meaningless. They are totally arbitrary. And when you're in network, the in-network contracted rate will apply to the service. And when you're out of network, the value of the service will be determined by an allowed amount set by the payer.
And for that allowed amount, is that something that you get to see as a provider, or is that something that they keep a secret?
So yeah, they do keep that a secret. There are some indications as to how a policy is going to pay. So each individual policy will have a reimbursement basis built into it. And those bases, they range from a percentage of Medicare or MNRP all the way up to something called usual and customary or reasonable and customary. And it's usually a percentage of that. And the way usual and customary is calculated is there's a metric and there's a committee that meets every year on this, and they assign using a metric that recognizes the geographic location of the provider, your zip code, the education level of the provider, so master's or PhD or doctor, and the risk that the provider must take in order to provide these services, which includes, the cost of your facility or your office, or you operating out of the back of your pickup truck. And then they use these three different percentages, and they apply it to a baseline value, a baseline number for a specific service. And then that generates a cost, an allowed amount, a reasonable and customary amount for that service. In addition to that, there are also a couple of different independent information sites like Fair Health that collect all of the data for each area. So Fair Health, which is originally created by Optum, and now they wish they hadn't done it, but they originally created this third-party independent organization to capture all of the claims in a given area, and then they generate, based on those claims, what is a reasonable amount to receive a specific service in a specific area. And so there's a couple of different ways that we can balance what is being set as an allowed amount, and we can generally directionally identify if the provider's allowed amount is meeting the policy reimbursement basis. For something like the Medicare rates, if a policy basis is 300% of Medicare, well, that's pretty simple. You just look up the Medicare rate for your service and then you multiply by 3. So that's pretty easy. And if they get it wrong, then you just say, hey, I think you got this wrong. Here's why you got this wrong. And they'll say, oh, sorry about that. And they'll fix it. Where it gets gray is when a policy has the reasonable and customary reimbursement basis, or usual and customary, and most policies do have that usual and customary out-of-network reimbursement basis. We're starting to see a shift now to the Medicare reimbursement basis policies, but for now it's still mostly reasonable and customary. That's when you start to get into this gray area where providers are granted the opportunity on the out-of-network basis to negotiate allowed amounts with the payer or with a third party. And so if an individual is forced to access their out-of-network benefits, then it is recognized by the industry that there may be a failure in the comprehensive healthcare network that has been paid for and is being provided to that member. And for that, the payer will negotiate a special one-time rate on each claim with the provider directly. And they'll say, okay, Mr. Provider, our person had to go to you because we didn't have you in our network. We don't want them to be subjected to balance billing. We don't want them to be subjected to unreasonable out-of-pocket costs. This account is important to us. So we're going to ask you if this amount of money will be acceptable to you for this service. And if so, we would like to ask you to waive your right to collect anything above this amount. And so that process is called claim negotiation, and it usually works through a third-party pricer or a vendor like Multiplan or Data EyeSight, something like that.
And Walter, I just want to be mindful, we've only got a couple of minutes left. I know you have a few more slides you'd like to get through. And I think this one other question that I'm seeing on here we can cover in one of your next slides.
Okay. So are you asking me to go to the next slide?
Yeah, let's just move ahead to the next slide,
cool.
So we can get through it before
sure.
time runs out.
So myths and legends, and our first myth that we want to talk about today is insurance companies try to deny claims. And I know that everyone, like your initial reaction to this is, well, I don't know, but I assume it is that they do try to deny claims. And I want you guys to know that that is absolutely true. All insurance companies, private or social, so Medicaid, Medicare, doesn't matter, try to avoid paying for medical care. And the way that they do that is by forcing care to be authorized, documented, billed correctly, and timely. And so when I worked for one of the major payers as a claims processor, I was schooled on how to deny claims, and we had a series of check boxes that we had to meet before we would approve a claim for payment, and it was fairly extensive on how we would go through that. But in order to get a claim paid, it is actually fairly difficult, which is why that service being provided as a courtesy to members is a big deal. Next myth is going to be in-network is cheaper than out-of-network. And so this is one of the big ones that's out there, and everybody knows that in-network is always cheaper than out-of-network, and there's a lot of fear surrounding using an out-of-network provider. And I just want the room to know that it is not always cheaper. This myth is made popular by insurance companies. Insurance policies can get complex. However, it's not brain surgery. The best way to understand your individual policy is to ask your provider and to work directly with them. If what your provider tells you lines up with what your insurance company is telling you, then it's probably right. But not always is in-network cheaper. The reason the myth exists is that insurance companies have greater exposure when members do not use their network, which is the reason the myth exists.
And on that, Walter, if you could answer really quickly, it seems like generally out-of-network deductibles and out-of-pocket maximums are significantly higher than the in-network ones, generally.
They can
Not
be,
always.
yes. They
And
can
then
be.
the other piece on that was from Gina's question, is it true that you're not allowed to waive deductibles with in or out of network? Can you speak to that just a little bit?
Yeah, so when we're in network, we have a signed contract between the provider and the insurance company that says, when we're putting our name on this and we're saying we will collect all of the members' cost shareables, all their coinsurances, all of their deductibles, all of their copays, and you, Mr. Payer, will pay these claims according to this rate in a timely manner. Out of network, there are rules and laws that govern this, but it starts to get gray, and this is where you start to see some fraudulent behavior where folks will say, hey, I'm going to buy you an airplane ticket and waive your deductible, fly down to my facility, and we're going to get you in here, and we've got free housing and all of this stuff, and that's called enticement, and you're not allowed to do that. That is illegal.
Thank you.
Yes, sir. Next myth is insurance is required to get quality health care. So everybody knows that if you're rich and famous, that you get better health care than everybody else. And I want you guys to know that that is not true. Getting high quality health care has more to do with geography than insurance status or spending. Just because we spend lots of money does not mean that we're getting a good quality service or product. And so I could spend lots of money on a service in one location and spend a lesser amount of money on the same service in another location and get a better service in the other location. That does happen and can happen. And so it is important that we know and trust our providers and do a little bit of research. Yeah, so that is all of the myths and legends. And Rowan, if we're out of time, we can stop there and, maybe we can circle back another time, or I defer to you, sir.
Yeah, I think if people have to go and people have already been bowing out when they need to, that's totally fine. I think for the sake of the recording, I would love to just spend 3 or 4 minutes just going over how to combat the fear-based communication, because I think that is a really important part of what we do.
Sure. Yeah, no problem. So fear-based communication, this is something that I see almost every day in my position, and the goal in talking about this is to better equip us to align clients and family systems to work with us and their insurance carrier. And the way that we do that, the method, is through transparent and forward communication. We do build trust. So one note here that I would just say is that setting appropriate expectations is important, and families turn to us when the problem is so bad they don't know what to do. The families are scared, confused, and exhausted, and we should be their ally. And that is really going to help the families move through that fear and make logical and rational decisions. So just real quick, the do's and don'ts on some of this stuff when we're communicating with people, especially about financial matters. We do want to acknowledge their emotions. We do want to be transparent. In the communication, we do want to set action steps for us and them. And we do want to follow those action steps with good communication. The things that we don't want to do, the things that we want to discourage, is supporting of fear-based decisions. And just to elaborate on that is we don't want people to seek care from a provider that they do not know or trust fully just because they're scared. We want them to seek care from a provider because the provider is the best provider to give them that care that they need. The other thing we don't want to do is to create adversarial relationships. We don't want to create situations where it is us versus them. What we want to create is the family working with us and their insurance company all together to get this family the help that they need. And the last do not is we don't want to guess. It's okay to say, I don't know, and I will follow up and let me get you that answer. And I'm going to set my action steps and I'm going to let you know what those action steps are. And I'm going to communicate with you following those steps. And so we do want to be in financial alignment. So everybody is very, very clear and heavily focused on the clinical alignment piece. And one thing that I've found very useful in my position is to basically merge the financial and clinical pieces together and have it known that we're all working together towards the same goal. So therapeutic relationships begin with trust. The financial relationship is no different. And it's okay to acknowledge that without the financial support, the therapeutic process can likely not begin. Understanding the process will help remove fear and create increased access to care. And so that was everything that we wanted to get through today. So thank you everybody for listening and for your time. And I hope that was helpful. And if there are any questions at this point, we'd love to just open up the floor and talk openly with each of you. So thanks again. And I will hang out for a couple minutes.
Well, really appreciate you going through that in such detail and with such candor and direct communication. Really appreciate that, Walter.
Yeah, no problem.
Thank you both, Walter and Rowan, for facilitating. This was really, really well done. And we will be making this available on the COPLA website so that folks can download it and access it later. So feel free to visit us at copla.org. It's actually changed to copla.org now. So, or coloradopla.org. And if anybody has any additional questions, you can always reach out to Walter. Can I go ahead and give them your email address, Walter?
Yeah, no problem.
Walter.baker@sandstonecare.com.
That's correct.
Great. Thank you both. Thanks again, Rowan, for helping us facilitate it.
Yeah, absolutely. Thank you, Walter, so much. And I think for everyone, yeah, just having Walter's contact information, if you didn't get anything else from this talk, is really valuable, just to have a real-time person that you can talk to who actually understands this process, because it is so complex. It's really hard to draw too many generalizations. I think a lot of it is just talking through how to handle individual situations. So if that's something that you're willing to provide for people, I think that's a huge resource.
Yeah, absolutely. To the community, I'm always available and happy to help out in any way that I can. So if you guys have strange one-off scenarios and you want to talk through it with somebody, just shoot me an email. We'll get on the phone and we'll talk it through.
Okay, thanks everybody.
Thank you. Take care. Have a great day.
I'm going to stop my share.